Welcome to another Case Med Minute video. This week, we're going to be talking about anemia through the lens of a step style question. So this is the question that we're going to be talking about. If you want to pause the video here, you can take a moment to read through and try to figure it out on your own. Otherwise, we're going to go sentence by sentence and pull out the key details. I think this is a great way to approach these style of questions because with each new piece of information, you're getting a better picture of what the exam writers want you to take out. That way, by the time you finish reading the question, you have an idea of what you think the answer is. So let's jump in. So the first sentence reads, a 68-year-old man with a history of chronic kidney disease, rheumatoid arthritis, and hypertension presents for evaluation of fatigue and exertional dyspnea. So there's our chief complaint right there, fatigue and exertional dyspnea. And this is a broad chief complaint. Our differential includes things like anemia. It could be something like heart failure, it could be respiratory, like COPD, could be something like deconditioning, a whole bunch of different things it could be. We know this question's about anemia because I told you, so we'll stick with that, but it's great to keep kind of a broad differential. The sentence also has a couple other key pieces of information. So the patient has a history of chronic kidney disease, which we know can cause anemia because it causes a low EPO and reduced red blood cell production. And then this patient also has rheumatoid arthritis, which is an inflammatory condition, so it can cause an anemia of chronic disease. However, we want to keep a broad differential. So we have this kind of older gentleman, and there's a lot of things that can cause anemia in an older patient. One thing that I always keep on the differential is colon cancer. So this can cause an iron deficiency anemia because you have this mass that's oozing blood over time, causing loss of iron and an iron deficiency anemia. You can also have potentially a myelodysplastic syndrome or MDS. So maybe this patient has, let's say, CLL. Could also have a nutritional deficiency, so something like folate or B12 deficiency. So some other things to keep in the back of our mind. The next sentence has a whole bunch of lab values, so let's just go through them one by one. So first, hemoglobin of 9.2 and MCV of 88. So I put the lab values down here at the bottom. So if you don't know them, that's totally fine. You'll get these values on the exam. For a male, normal hemoglobin is 13.5 to 17.5. Here it's 9.2. So there you go. We know this patient has anemia. MCV is 88, and the normal MCV in this chart is 80 to 100. So 88 is normal. This is a normocytic anemia. Next, we're given a reticulocyte count of 0.6. The normal retic count is 0.5 to 1.5. So this is low normal, so I'm going to mark it in red. And then our serum ferritin is 220. For a man, normal is 20 to 250. So 220 is kind of high normal, so I marked it in green. Whenever I see an elevated serum ferritin, I think of anemia of chronic disease. So the inflammation is causing this increased ferritin. And then the lower tick count, the blood cells are just being produced at a lower rate, could be caused by still a lot of things. But like I said, this ferritin is really making those alarm bells go off in my mind for anemia of chronic disease. Next, we're given this transferrin saturation, which is 14%. I couldn't find it in the chart, but I'll just tell you that the normal transferrin sat is 20 to 50%, so this is low. And we're also given C-reactive protein of 18. This is elevated. A normal CRP is less than 10, so this is an indicator of inflammation, kind of fitting with our whole thought about this being an anemia of chronic disease type picture. And then the final lab that we're given is creatinine. Normal creatinine is 0.6 to 1.2, and here it's 2.8, consistent with CKD, which we already know this patient has, so that's probably what's going on. Okay, so next we're going to kind of think about these labs that we've been given and interpret them. So we know that our ferritin is high, and we know that our transferrin saturation is low. So looking at this chart from first aid, again, this fits with the picture of anemia of chronic disease. In iron deficiency, conversely, we would have a low ferritin, right? Because iron is low, so you need to dip into the stores of iron, which is that ferritin. So that will be used up and ferritin will be low as well. Next, we're given some results from a blood smear. So it says the peripheral blood smear shows normocytic, normochromic erythrocytes. So normocytic, normochromic, meaning normal in size. This fits with, we already knew the MCV was normal. However, in something like an iron deficiency anemia, early on, you could still have a normal MCV, but you would probably have hypochromic erythrocytes. So again, we're still not really thinking this is an iron deficiency anemia. And then it says it's without schistocytes, so it's not a hemolytic anemia or spherocytes. So no spherocytosis. This is not a hereditary spherocytosis picture. And this is probably also not an autoimmune hemolytic anemia, which would also present with spherocytes. Okay, so let's think about these answer choices. So A says decreased erythropoietin production and increased hepcidin-mediated iron sequestration. So the first part, decreased EPO production, well, the patient has CKD. So that could definitely be true. And then for the second part, let's just recall what anemia of chronic disease is. This is a screenshot from first aid. So when you have inflammation, you have increased hepcidin. And this causes a decreased release of iron from macrophages and decreased iron absorption. So iron would be low because you're kind of keeping it sequestered, not releasing it out into the blood. And this is associated with a whole bunch of conditions, including, as it says here, CKD, which our patient has, and also autoimmune diseases such as rheumatoid arthritis, which our patient also has. So it seems like this is potentially a good answer, right? Decreased EPO and increased hepcidin-mediated iron sequestration. What about answer B? So chronic GI blood loss leading to iron deficiency anemia. So again, maybe, but like we talked about, our ferritin is high normal. We would expect that to be low if this was an iron deficiency anemia, and we would also expect probably a hypochromic picture on the blood smear. So probably not this. What about autoimmune destruction of erythrocytes? So this is talking about an autoimmune hemolytic anemia. And if this were true, we would probably see spherocytes on blood smear. We might also see an elevated reticulocyte count as the body's trying to like compensate for this anemia. However, this is complicated for this patient because of the CKD, which we know will just kind of suppress red blood cell production at baseline. How about answer D, vitamin B12 deficiency? So possible, but if this were true, we would expect the MCV to be high because vitamin B12 and folate deficiencies cause a macrocytic anemia. And then finally, what about bone marrow infiltration by malignant cells? Again, possible, but if this were true, we would probably see something on the blood smear, depending on what type of cancer it was. So maybe a leukocytosis, maybe we would see teardrop cells. There would probably be something going on, which we do not see. So seems like A is the best answer here. So again, I think it's really helpful to kind of go through these questions with a fine-tooth comb, especially when you're practicing. Try to pick out what you're getting from each sentence as you read it. And as you notice here, we kind of thought that the answer was going to be the CKD and the anemia of chronic disease before we even started reading the answer choices, which put us in a really good place to get the question right.